All right, so welcome again to the next session. So again, today is going to be a sharing session of cases that I see last year and also maybe mistake that have been made or some interesting case today. So we will start with the first case. This case is very interesting. It's about 34 years old Chinese man who presented to me with bad shortness of breath, even at rest. She actually presented in Malacca in outside hospital, and they do echo over there and was told that one of his valve is leaking. And surprisingly, he was told that no intervention was needed and the patient only need medication. Added information, she does not have any systemic symptoms, does not have any fever, nor does she have any other signs of infective endocarditis. So I see this patient in clinic, so we do an echocardiogram for the patient. So this is the echocardiogram of the patient, and you can see here on the parasternal long axis view. So the first thing that you can see is that the LV is dilated, right? You can see that ejection fraction is somewhat depressed at 46%. So at this at 2D. And when we look at 2D with color here, that what you can see here is actually severe aortic regurgitation. So this patient has severe aortic regurgitation. And the aortic regurgitation is actually eccentric. I think that's very important to ascertain the direction of the AR, because remember, direction of the AR can give us idea of the etiology of aortic regurgitation. So, for example, a central aortic regurgitation is normally due to degenerative calcification, like in old people with calcified aortic valve, or rheumatic aortic stenosis, or someone with dilated aortic root. Then you will have a central direction jet. An eccentric jet most commonly is due to a flail or prolapse of the opposing leaflet. Okay, it can also be due to infective endocarditis or rupture of sinus of vas alba. So as you can see from this right image here, you can see that the jet is directed eccentrically, directed to the anterior mitral valve leaflet. We also see mitral regurgitation, and when we see someone with poor ejection fraction, dilated LV, and mitral regurgitation, so most likely this is LV functional mitral regurgitation. So the MR is, as the LV dilated, pull up the papillary muscle, and as it pull up the papillary muscle, it pull up the leaflet, and it causes tethering and tenting of the mitral valve leaflet. However, for this patient, the mitral regurgitation is not only in systole, but also in diastole, at late diastole. So why does this patient have diastolic MR as well? So the reason is because of the aortic regurgitation, the LV EDP is so high that even at end diastole, where the valve is supposed to be closed, you even see at that time mitral regurgitation. So we see an eccentric jet directed to the anterior mitral valve leaflet. Okay, and importantly, when we assessing aortic regurgitation, it's important to see what is the LV dimension, because in someone with severe aortic regurgitation, if they are symptomatic, then yes, you send for surgery. But if they are asymptomatic, you don't send for surgery unless there are signs of LV decompensation. What are signs of LV decompensation in severe aortic regurgitation? One is ejection fraction that is less than 55%. Then is systolic dimension, LV systolic dimension that is more than 5 centimeter. And you can also index the LV systolic dimension to body surface area. Is it more than 2.5 centimeter per meter squared? So that is also one of the indication that the patient needs to go for surgery. Okay, so we have someone with severe aortic regurgitation and already have LV decompensation here, right? Then so I wonder why, when the patient was in outside hospital, was not sent for surgery. And this is a problem that we encounter many times, where there's not a lot of people that are very well versed in managing valve problems. And sometimes they miss certain things. So basically just what I do as well, like if let's say you are doctors outside, if something that you don't know, ask or try to ask someone that know. Don't pretend you know, because that will be not fair to the patient. Same also for me, as my expertise is echocardiogram, valve, and thick wall cardiomyopathy. So for example, if there's something like on ECG, that I'm not sure about, I will ask, rather than manage myself. Always important to know what is your own limitation. So we look at this zoom view of the aortic valve. Okay, important to see at the zoom view. And if you look at the zoom view here, what do you see? So this is non-coronary cast, and that is right coronary cast here. And straight away you can see that that right coronary cast here. Look at that right coronary cast there. It's actually flail. So now we have the mechanism of the aortic regurgitation, which is flail of one of the leaflet, causing an eccentric jet directed to the opposite direction. Okay, so that's why 2D is very important. Now I just go back and wanted to show you the color view here. What else do you see in the color view here? All right, you will see the regurgitation, and also you see the dilated left ventricle there. Okay, so now you see that we know what is the mechanism of the aortic regurgitation. That's why 2D is very important. Okay, and then this is a short axis view. This is a 2D short axis view. It is difficult for me to ascertain the number of leaflets. So this is the non-coronary cast. That is a right coronary cast and left coronary cast. There is a suggestion when you look at this aortic valve that this leaflet and this leaflet might be fused, but I cannot say for sure. However, the likelihood of bicuspid valve is quite high in this case because it is quite common for this fused leaflet to prolapse or flail and cause aortic regurgitation. So maybe this is bicuspid aortic valve. So this is a still image of the aortic regurgitation, and we measure the vena contracta here, which is the narrowest point here, which is 6.6 millimeter. Anything that is above 6 is considered severe. So I just wanted to remind you, for aortic regurgitation, the parameters for severe aortic regurgitation are vena contracta that is more than 6 millimeter, effective regurgitant orifice area that is more than 0.3 centimeter square, and regurgitant volume that is more than 60 mils. Other supportive findings is, and two of the most important are the hollow diastolic flow reversal in the descending aorta, and also hollow diastolic flow reversal in the abdominal aorta. Now, pressure half time, it is useful is if it is short. So a short pressure half time, less than 190 milliseconds, is very specific for severe aortic regurgitation. However, a long pressure half time, it is not used to rule out severe aortic regurgitation because it's quite normal to see someone with chronic severe AR but yet have long pressure half time. So interestingly, this is the M mode across the mitral valve. And in the previous session, I've tell you a phenomenon called early diastolic closure of the mitral valve. So this is opening of the mitral valve. So this anterior mitral valve leaflet, and this is posterior mitral valve leaflet, right? And this mitral valve leaflet should open until end of diastole here. It should open until here, right? But if you notice, the mitral valve closed very, very quickly before the end of diastole. So why does that happen? So that is because the LVEDP in this patient is so high that before the end of diastole, the mitral valve already closed. The pressure inside the left ventricle before the end diastole is already higher than the pressure inside the left atrium. Therefore, sometimes you can also see diastolic mitral regurgitation. Okay, so this is early closure of the mitral valve before the end of diastole. If let's say the aortic regurgitation is even more severe, to the extent that the LV pressure is actually higher than the aortic pressure, even before end of diastole, you can actually see early opening of the aortic valve. Okay, so this is the phenomenon. One is early diastolic closure of the mitral valve, and if become more severe, you can also see early diastolic opening of the aortic valve. And this is the continuous wave Doppler across the aortic valve, and you can see the pressure half time is quite short at 79 milliseconds. Remember, this is specific but not sensitive. So we have many parameters here that show severe AR. So there is no doubt that the patient have severe aortic regurgitation. We know the mechanism, but we not yet know why this patient have flail on that particular leaflet. Now, this is the descending aorta. And if you notice, so this is your probe, right? And the blood should flow downwards. Okay, this is descending aorta, it should go downwards. Remember that blue is away from the probes and red is towards the probe. Now, even though you have a blue flow here, but you also have a lot of red flow during diastole. So you have a blue flow and you have a red flow during diastole. So this is something that you need to take care of, because this is a marker of hollow diastolic flow reversal, which you can actually see here in the Doppler here, and here, and here. So this is a severe aortic regurgitation, the marker of severe aortic regurgitation. So as I look at this transthoracic echocardiogram and the patient is in front of me, so what is the thought inside my head? And there are so many parameters here that show severe aortic regurgitation. Wide vena contracta that is more than 6 millimeter, diastolic mitral regurgitation, premature diastolic closure of the mitral valve, and very short pressure half time. So I have no doubt that this is severe aortic regurgitation. The patient is symptomatic. So even if the LV is okay, even if the dimension is okay, the fact that this patient is symptomatic, this is already an indication for aortic valve replacement. So the fact that the patient see a cardiologist outside and the advice is medications and regular follow-up is actually very dangerous. And not only that, the patient also have LV decompensation. The EF is 46%, and the LV and systolic dimension is already more than 25 millimeter per meter squared. Okay. So at the same day, I sent him to another surgeon to be reviewed, and actually he arranged for aortic valve replacement for this patient. So he underwent aortic valve replacement quite quickly on the 29th of July 2020. What follows are the intra-op transesophageal echocardiogram of this patient with severe aortic regurgitation. Okay, this is a mid-esophageal long axis view. And finally, what we see here is the mechanism, but also the reason why the patient has severe AR. So this is the non-coronary cast. This is what we assume to be either right coronary cast or fused right and left coronary cast. You can see this leaflet is flail, and you can also see a mass that is attached to this leaflet. So this is a very suggestive of a vegetation. So this patient does not present with infective endocarditis sign and symptoms, but in fact have vegetation that caused the aortic regurgitation. And you can see here the regurgitation going opposite towards the anterior mitral valve leaflet. Remember that this is TEE, and therefore the view is opposite to those that you see in transthoracic echocardiogram. And lo and behold, when we do short axis view, we can confirm that in fact this patient do have bicuspid aortic valve. This is the non-coronary cast. This is the fused right and left coronary cast. So this patient have bicuspid valve type 1 with 3 sinuses, and the part that is flailing is this fused right and left coronary cast that you can see there are vegetation attached to it. Okay. So finally, with the combination of transthoracic and transesophageal echocardiogram, we actually get the diagnosis of severe aortic regurgitation because of flail, fused leaflet of the bicuspid valve with infective endocarditis. So this is the diagnosis, the full diagnosis for the patient, right? So the patient underwent mechanical aortic valve replacement. So this is the post-op mechanical aortic valve replacement, and you can see that the aortic valve is functioning well. There is no stenosis or regurgitation of the aortic valve. So we thought that this is the end, you know. We catch the patient, albeit slightly late. We change the aortic valve. We know the diagnosis. Then that should be it, right? The story continues. Now, unfortunately, because normally when we send a patient to the surgeon will take over and the primary team changes so that the cardiologist no longer see the patient. Now, when the surgeon do the operation and they look at the intra-op transesophageal echocardiogram and the fact that there are vegetation there, somehow or rather, no antibiotic was started for the patient. So the patient was not given antibiotic throughout this admission. Okay. No blood culture was done after the operation. and the patient does not get any antibiotic before or after the operation. And this confusion is very understandable because the patient presented not like infective endocarditis patient. Okay, the transthoracic echo, because it's not so clear, we can't really determine any vegetation there. And the only way we see vegetation is from the transesophageal echocardiogram. So after 2 days of operation, they do a transthoracic echocardiogram. It shows a normally functioning mechanical aortic valve, so that's fine. And everyone thought that AVR was successful and the patient went back home to Malacca. Now remember that the diagnosis of infective endocarditis was never ascertained, was never officially diagnosed, because this is retrospective after we look back at the echocardiogram. Okay? So what happened next to this patient? So I actually give my patient my personal phone number the first time patient see me in the clinic. In fact, I was quite happy by the fact when the patient see the cardiologist outside of IJN, they managed wrongly, and I managed to catch the IT regurgitation that is severe. So I thought that I did a good job. I managed to, get the patient AVR, and all is very well. However, at early October, I get WhatsApp from his wife saying that his pulse goes up and down randomly. Sometimes it go very high, sometimes it go very low. Obviously, the first thing that I think about after aortic valve replacement is that the surgeon might inadvertently touch the AV nodes, and this is conduction issues. Even though it is bad, but it's not so bad, it can be easily treated by a pacemaker. So he come to see me in clinic. So I asked him to repeat an echocardiogram. But while waiting for the echocardiogram, he developed a brief episode of loss of consciousness. So I have to admit him. So the following was the transthoracic echocardiogram that was done in ward when I see him again. So what do you see here, right? Unfortunately, if you notice here, the aortic valve has dehisced. So they are rocking of the mechanical aortic valve here. And whenever we see a rocking valve, the first thing that we think about is always infective endocarditis. We see a rocking valve in the parasternal long axis view, and we see a rocking valve in the apical 5-chamber view. So this is a zoom view. Again, you can see this rocking valve here. The color is not very illuminating, as I cannot see any obvious aortic regurgitation from the color view, but there is no doubt that the appearance of the mechanical aortic valve is really not normal. So this is the short axis view of the mechanical aortic valve. It is quite difficult to see mechanical aortic valve in short axis view and to see whether there's any abnormality. The cavity that you see here can be normal post-mechanical or bioprosthetic aortic valve replacement. So the short axis view is not really illuminating. The 5-chamber view does show aortic regurgitation, but still, I cannot tell whether it is severe or not severe. However, in my mind, with that kind of rocking and dehiscence of the aortic valve, I'm sure that we are dealing with a severe aortic regurgitation here. Now, this is an apical long axis view. Again, you can see aortic regurgitation here, but the pressure half time it is not so short. But this clean sheet for me, this is severe aortic regurgitation. Remember, I showed you in the previous images. In this view, should always be blue flow only. So blue flow meaning that the flow going down the descending aorta. Okay, but why do you have red flow towards the probe? So this is reversal, and you can see here they are diastolic reversal in the descending aorta. So what do I think now after this transthoracic echocardiogram? So at first, before doing the transthoracic echocardiogram, I was thinking of AV nodal dysfunction due to complication from the aortic valve replacement. However, looking at this echocardiogram, the AVR appeared to be violently rocking with dehiscence. Obviously, the first thing in my mind is infective endocarditis, even though there is no vegetation here. It is also tricky to catch the aortic regurgitation in this patient from color, from both parasternal long axis view and short axis view. Remember that this patient was not treated initially, right? Remember that this patient was not treated initially with infective endocarditis, even though he have vegetation. Intraoperatively, we can see vegetation that we missed. So therefore, this vegetation that this patient having now, the hissing that he's having now, in my mind, is because of the inadequate or non-treatment of the infective endocarditis that should happen during the first operation. Okay. So now that I see the dehiscent, so we take 3 sets of blood culture, ESR, CRP, and amazingly, all of these are normal. Even procalcitonin is normal. Patient does not have any temperature. But because of the dehiscent, I look back at the intra-op TE that I showed you just now. Then I said, okay, there are vegetation at the time, and patient was never given antibiotic. Even though all my bloods are negative, I'm pretty sure we are dealing with infective endocarditis. So we started the patient with antibiotics. His pulse pressure is very wide. He needs surgery urgently because you can see that the valve is rocking very violently and the valve might dehiss and fly off at any time. So I did one more transesophageal echocardiogram to ensure that I did not miss anything. So the following are the transesophageal echocardiogram. This is not an intra-op, rather this is on table. I think this is in ICL. And you can see here in mid-esophageal 5-chamber view, you can see here, this is an abscess, right? You can see formation of an abscess here, right? And we can see at the long axis view here, right? There are turbulent flow across the aortic valve that can be normal. And there is also aortic regurgitation. So we can't really see here how severe is the aortic regurgitation. So this is the short axis view of the aortic valve. And you can see here the formation of abscess. So this soft material here is an abscess. There's an abscess here. So there are abscess here in the short axis view. And I go deep transgastric. So deep transgastric is 45 centimeter on your probe, and you anti-flex the probe. And finally, here we can demonstrate how severe is the aortic regurgitation. So the patient have severe aortic regurgitation. We put a continuous wave Doppler across the aortic valve, and we can see very short pressure half time. In fact, when we do a 3D unfast view, so that's the mitral valve, that's the tricuspid valve. In front of that mitral valve is the aortic valve here somewhere. But here, the bulge here is actually the abscess because of our infected mechanical aortic valve. So what is my thought before I send the patient for redo AVR? So with the TE that I do, there is no doubt in my mind that this patient now have florid infective endocarditis with severe paravalvular leak. The evidence this is IE are, number one, previous IE that was not treated with antibiotics, valve dehiscence, obvious abscesses with severe paravalvular leak. This time around during the operation, what they do is we actually send multiple tissues to send for cultures for infection. And we also ensure the patient receive adequate duration of antibiotics pre and post second operation. The patient actually completed 2 weeks of antibiotics before going for AVR. So this is the second AVR on the 20th of October 2022. What follows are the final couple of views of the intra-op redo AVR of this patient. So this is a mid-esophageal long axis view, and we can see that the mechanical aortic valve is normal. This might seem like abscess, but remember that just during the operation or just after the operation, that can just be a hematoma that can resolve by itself. This is a deep transgastric view intraoperatively, again showing normally functioning aortic valve. So this is the second operation. So what is the culprit? Finally, the multiple tissue biopsy from the operation grew Staphylococcus warneri, which is coagulous negative staphylococcus, which is a very rare cause of infective endocarditis in a native valve, but cons, it's one of the commonest cause of infective endocarditis in a prosthetic valve. Okay, so the patient completed antibiotic via advice of the ID physician in the ward. So what are the lessons to learn in this patient? You remember this patient underwent 2 aortic valve replacement. In fact, there are some more story after this, but because I don't have the images, so I think I just stop here. So what are the lessons that we learned? I think the proper assessment of IR severity are very important. Okay, because we operate on severe AR. So if you don't know what is severe AR, you cannot manage patient. Symptoms is important, and signs of LV decompensation is important. Remember that the guideline changes with time, so you have always to update yourself. As far as I know, the sign for LV decompensation in chronic severe AR is EF that is less than 55%, LV systolic dimension that is more than 5 centimeter, LV systolic dimension index that is more than 25 millimeter per meter square. Remember that if you don't know, never pretend that you know. None of us know every single thing. Okay, and especially to those who practice, as you go to private practice, then you practice alone. And when you practice alone, if you don't know, please ask or refer to someone who knows. I also do the same. Sometimes certain very important findings can either be missed or act upon, like the findings of vegetation in this case in the first intra-op TE. Even if blood culture, inflammatory markers, or even symptoms does not suggest IE, it is still possible. And the first thing anyone should think about anytime they see valve dehiscence. AR severity assessment can be very tricky and in multiple windows and even TEE. An expert need to be consulted in this situation. So that is my first case that I hope you find very interesting. That is really affected me quite a lot. Now we go to our case number 2. I have here a 25-year-old female. So I'm one of the cardiologists in IJN that is also in charge of pregnant lady with heart disease. So this patient was referred to me for management of INR because she had mechanical aortic valve replacement. Remember, a pregnant lady with a mechanical aortic valve or mechanical valve, mechanical mitral valve is straight away considered high-risk pregnancy. Don't manage this patient by yourself. Please refer to a cardiologist that have interest in managing pregnant lady. Okay, because the management is not easy. Just to give you a snapshot of the management, normally there are 2 approach normally. What guidelines say is that during the first trimester, if they say the warfarin dose is less than 5 milligrams per day, you can continue with the warfarin, continue until the 3rd trimester, but off towards the end of pregnancy because you want to prepare the patient for delivery. The other approach, and this is the approach that is done in IJN because of the experience with warfarin, whereby the patient either have bleeding or fetal miscarriage, is that we actually stop the warfarin and start the patient on subcutaneous Lexane. But importantly, compulsorily, you have to monitor the factor 10A if you want to go into that approach. Okay, so that is just a segue. So she was referred to me for management of INR for mechanical AVR. She is primigravida at 8 weeks gestation. She is asymptomatic. I saw her in my clinic and did TTE as a baseline to manage her during pregnancy. Okay, and when I look at the transthoracic echocardiogram, then I know that I'm dealing with a big trouble. Okay, so this is a parasternal long axis view. Number 1, you can see that the ejection fraction is depressed as 41.8%. Remember, in pregnant lady, a depressed ejection fraction is straight away high risk pregnancy. Number 2, if you look carefully at the mechanical aortic valve, not as obvious as previous patient, we can see that the aortic valve is rocking slightly. Okay, it's never a good news. Someone have a rocking aortic valve, mechanical, and it is even worse if the patient is pregnant. Okay, You can see that the LV is dilated at 6.1. Remember, for female, the upper limit is 5.2 and for male is 5.8. The systolic dimension is also high. Upper limit for male is 4 and for female is 3.5 centimeter. Okay, and when you look at the parasternal long axis view, it's difficult, but there are definitely paravalvular regurgitation there. So we take a zoom view of the echocardiogram. They are what seems like a bubble inside the LVOT here. Don't worry, when you have a mechanical aortic valve, it is normal to have this microcavitation, so that is normal. When we look closely at the LVOT, they are a suggestion that this patient have aortic regurgitation here. It is not definitive, but definitely very suspicious when you see the aortic valve that is rocking like so. So again, we can see the rocking aortic valve, right? And again, second time I show you, this is the mitral valve, that's the anterior mitral valve leaflet, and that's the posterior mitral valve leaflet. Even though not as severe as before, you can see that the mitral valve doesn't open normally. You don't see the normal DEFAC, but rather there is early diastolic closure of the mitral valve before end of diastole, suggesting that the AR is severe and they are also very high left ventricular and diastolic pressure. Now, if you look at the echocardiogram here, I wanted to also draw your attention to this. You can see turbulence flow just below the posterior mitral valve leaflet here. What is that turbulent flow below the posterior mitral valve leaflet? So that is very intriguing for me. What is that turbulent flow below the posterior mitral valve leaflet? Okay. So in summary, so far what we have seen, patient that is pregnant, mechanical aortic valve that appear to be dehiscing, okay, rocking. So it is very worrying. AR appear to be severe. Why? Because of the rocking of the aortic valve and the early diastolic closure of the mitral valve. So what shall we do next? So this is a short axis view of the aortic valve. So remember, I told you that short axis view of the mechanical valve is usually difficult to interpret because what we see here can be normal post-prosthetic valve. And when we look at this view here, we can see that the regurgitation actually occupied half. Okay, that is the regurgitation here. The regurgitation is from here to here, from 6 o'clock to 12 o'clock, almost half the circumference of the aortic valve. So truly, this is a severe aortic regurgitation. And this is the apical 5-chamber view. Again, you can see rocking of the aortic valve, and you can see the aortic regurgitation at the side here, but we can't really tell the severity based on the color here. Now, this is a short axis view, and that is the mitral valve, right? That's the anterior mitral valve and posterior mitral valve leaflet. But finally, we have our answer of why there is an abnormal flow below the posterior mitral valve leaflet. So the reason is the aortic regurgitation is so severe that it actually swirls below the posterior mitral valve leaflet, right? So I show you back from the beginning. So what happened? All right. So this is the aortic regurgitation. This is the aortic regurgitation. So the AR is so severe that it go there, it turn around, and what you see is the tail of that aortic regurgitation. It go from here and go down here. And that's the tail of that aortic regurgitation. That's how severe the aortic regurgitation. And finally, we can see in our mitral valve view here. So this is the aortic regurgitation there. Now, this is the descending aorta. Remember that what we want is only blue flow going down, but we can see a lot of red flow. Again, telling us that this is a severe aortic regurgitation. This is the continuous wave Doppler across the aortic valve. The pressure half time is not short. It is more than 190 milliseconds. But remember, I say that this is not sensitive, but specific. But we can see hollow diastolic flow reversal in the descending aorta. So looking at this transthoracic echocardiogram here, okay, so what is my thought? Okay, basically, I'm already nervous, okay? Pregnant woman with mechanical AVR is already high-risk pregnancy even when the AVR is working well. In this case, we have a rocking AVR with what seems to be severe paravalvular leak. Okay, so how do I know this is severe? When you have a rocking mechanical valve, normally it is severe anyway. But at short axis view, you can see that the leaking actually fulfill almost half the circumference of the mechanical aortic valve. Hollow diastolic flow reversal in the descending aorta, premature diastolic closure of the mitral valve. Furthermore, the LV is not normal with depressed ejection fraction and dilated left ventricle. So this is an extremely high-risk pregnancy, and termination should be strongly considered. Whenever you see a pregnant lady and you wanted to talk about termination of pregnancy, remember that termination of pregnancy is never a decision of a single person. As a single person, before you do a multidisciplinary team meeting, you should never say to the patient that they need to terminate their pregnancy. Never. Because this need multidisciplinary team meeting. I will show you my next case of a pregnant lady in which the cardiologist that see the patient, without discussing with anyone, counsel the patient to terminate the pregnancy, causing undue trauma to the patient. Okay. So after doing that transthoracic echocardiogram, obviously when we suspect valve dehiscence, then I go and do transesophageal echocardiogram. So this is the transesophageal echocardiogram, mid-esophageal long axis view, and lo and behold, now we have no doubt. So remember that when we do TEE, this is posterior and that is anterior, right? When we do TTE, that is anterior and that is posterior. And we can see how severe it is, the regurgitation at the posterior part. At the posterior part of the aortic valve, of the mechanical aortic valve here. And when we look at the short axis view, this is what I show you from the transthoracic echocardiogram. We can see that the jet occupied almost half the circumference of the mechanical aortic valve. The mid-esophageal 4-chamber view, we can see the tail of this AR that actually swirl and go to the posterior mitral valve leaflet, what you see in the transthoracic echocardiogram just now. This is the transesophageal echocardiogram, deep transgastric view. So you can see also severe paravalvular aortic regurgitation here. So what is my first thought about this case? Okay. Again, I want you to remember, this is someone that is 8 weeks pregnant, come with mechanical aortic valve replacement. Actually, the issue is only to manage the INR, right? To start on subtype fixate and to monitor the factor 10A. But unfortunately, both TTE and TEE really reinforce us that the AR is severe. It is paravalvular and is associated with dehiscence. Remember, I told you, if you see dehiscence, it is IE until proven otherwise. For our first case just now, it is very complicated. So this is our second case. So is this infective endocarditis? So of course, like I said, always the first diagnosis is IE. But what we do is we take blood culture, we take ESR, CRP, and all are normal. Having said that, in our first case, someone with Staphylococcus warneri is also normal, right? So we cannot simply rule out infective endocarditis. It can be very tricky sometimes. Unlike the previous case though, when we look back in this patient echocardiogram, even the initial echo after the surgery have already shown moderate aortic regurgitation at exactly the same place that we see right now, only not as severe. So what we think is that the aortic regurgitation has progresses gradually from moderate to severe over these subsequent years. Another thing that is different from our initial case. In our initial case, the patient was never given antibiotics. But this patient, she actually completed antibiotics. The reason she having the initial operation was infective endocarditis, but the antibiotic was completed, the long course of antibiotics. So this is a pregnant lady. So we do an MDT with surgeons, with ID physician, with cardiologists, with pediatric cardiologists, with maternal fetal specialists. So after I presented the echo, all of us agree that in this patient, and thankfully the pregnancy is only 8 weeks, it is simply too high risk. and the patient need to be advised for termination. Sadly for the patient, in fact, they are planning to get married 2 weeks after. When I see them for the consultation for the first time, they are planning to get married in another 2 weeks time. So all of those have to be cancelled. So we felt, all of us think that this is not infective endocarditis. We think that this is an early surgical failure. Patient was counseled and safely underwent termination of pregnancy. Ideally, I wanted to push for redo AVR earlier, but after we do the termination, patient insists on getting married first and just wanted to do AVR December, but it's already done December last year. And she was discharged fairly well. So that is my second case today. So just to recap, our first case is someone with severe IT regurgitation due to the fused leaflet of the bicuspid valve and infective endocarditis that might be missed during the first intra-op operation. Our second case is a pregnant lady with mechanical aortic valve that is also dehisced, but this is an early surgical failure. And I've shown you how to assess severity of aortic regurgitation in both of these cases. Now let's go to our case number 3. We have here a 42-year-old man with exertional dyspnea. So this is a Chinese gentleman, known ECG with right bundle branch block. For quite wide QRS was 10 years ago. At that time, it was told that RBBB was benign. We do know that RBBB can be benign, unlike LBBB, and was told to have no structural heart abnormalities. For the past 2 months, have some shortness of breath on exertion. So especially this case was referred to me by Dr. Mazni, one of our pediatric cardiologists, because he's taking care of the patient when the patient was a child. So he see this patient before, and his impression was the echo was reported as normal, but I wanted you to see him, as I think the left ventricle looked a little bit funny. So the following are this patient echo images. The EF was reported as 50%. Okay, so this is the parasternal long axis view. Okay, if you look at the parasternal long axis view, the LV dimension is at upper limit for normal. Remember, upper limit for male is 5.8 diastole and 4 centimeters systole. The ejection fraction also seems to be borderline. Okay, can be normal. When we look at the patient color, there is no obvious left-sided valvular abnormalities, and the patient did have wide QRS complex when you look at the ECG here. Now, when we look at the apical 4-chamber view, okay, those of you who are familiar with echocardiogram might already think about what is the diagnosis here. So what caught my eyes is, look at here, there are prominent trabeculation here, right? So basically our heart, the endocardium, usually are formed by 2 layers. One is a trabeculated layers, one is the non-trabeculated or compacted layers. In those of us who are normal, normally the trabeculated layer should not be more than 50% of the compacted layer, right? But in this patient, if you notice here, there's a lot of trabeculation here, right? A lot of trabeculation there. Now, I asked the patient whether he is an athlete, because remember, athletes can have hypertrabeculation, okay? I asked the patient whether he is pregnant. Obviously, he cannot be pregnant because, he's male. So there is no reason why he should have hypertrabeculation. Okay, so the first thing that I think about is this LV non-compaction. Am I dealing with LV non-compaction here? Now, the important thing when we are dealing with LV non-compaction is to look at short axis view, because the diagnosis is made for echocardiogram in short axis view. This is an apical long axis view. Again, you can see prominent trabeculation. We can in fact see 1, 2, okay, about 2 prominent trabeculation here, 1, 2, and maybe 3 prominent trabeculation here. And this is the short axis view at the papillary muscle level. This is the trabeculated part, and that is the compacted layer. Okay, let's go to the next image. So this is the next image. Okay, upper left. What I wanted to show you on the upper left is 3 prominent trabeculation. 1, 2, and 3. So this fulfill the Stolberger criteria for LV non-compaction. Okay, where we see 3 or more prominent trabeculation at short axis view at apex. When I zoom, when I freeze at short axis view, and I measure the ratio of the non-trabeculated layer to the non-compacted or trabeculated compacted layer, I can see the ratio is more than 2. So also fulfill the Jenny criteria. So this patient actually fulfilled 2 criteria, fulfill the Stolberger criteria and also fulfill the Jenny criteria for LV non-compaction. However, for me, right, because prominent trabeculation is fairly common, like I said, if you're athletes, if you're pregnant, if you're African American, you can have a normal prominent trabeculation. So before diagnosing someone definitively with LV non-compaction, what I want is an evidence that the LV is dysfunction. Okay, is the EF down? Or the other way to do it is by doing global longitudinal strain. Is the GLS down? Because if the GLS down, then for sure the tissue is not healthy. Now, before we go to GLS or cardiac MRI, so we can also look at tissue Doppler. And tissue Doppler really helped me in this situation. Remember that the patient is young. The patient is 40 years old. You can see that the septal E prime is 6.49 centimeter per second. Remember that the threshold is 7. But that threshold 7 is for someone that may be 50, 60 years old. For someone that is 40, we expect it to be way more than 7. But this patient is 6.49. When we look at the lateral tissue, it is 9.63. The threshold is 10. Again, the patient is young. It should be way more than 10. 9.63 is pretty low. And looking at this, in my heart, I already think maybe 90% sure that we are dealing with LV non-compaction. So what is my thought process? So I was struck basically by 2 things. Okay. Number 1, the EF looked borderline to me, even though it was reported as 50%. B, I can see prominent trabeculation, but it fulfilled the criteria, but only barely, right? It's not very obvious that it fulfilled the criteria. So, but unless there is an objective demonstration of LV dysfunction, I hesitate to diagnose someone with that. I can see that the tissue Doppler is low, so the tissue is unhealthy. So what I do is that I take the echo, I use my Tomtec software, and I get the global longitudinal strain. And lo and behold, you can see that the GLS is actually very low at negative 13.1%. Remember that the normal value is more negative than negative 18%. So this is quite significantly low, and there's no reason why this patient should have a low GLS. So now you're having a patient with low GLS, prominent trabeculation, right? So now I have no doubt that what I'm dealing now is someone with a definitive diagnosis of LV non-compaction. I also do the LA reservoir strain, which is also abnormal at 32.1%. Normal is more than 35 to 40%. The RV function is also down with RV longitudinal strain of negative 10. Normal should be more negative than negative 25%. So what is my final thought for the third case? I actually do analysis of strain to ensure I make the correct call. I just not simply diagnose someone with LV non-compaction. And true enough, we actually see significant LV and LA reduction in strain. If you don't have strain, don't be shy to do cardiac MRI, because that can also be very, very helpful to you, because the EF that you get in cardiac MRI is very accurate. And in this patient, we also do cardiac MRI, and EF is actually low at 44% with some mid-wall fibrosis. So I formally diagnosed with LV non-compaction. I think he have heart failure with mid-range ejection fraction, and actually start him on the cocktail of dapagliflozin and Presto and bisoprolol simultaneously, because the patient can tolerate, the blood pressure is actually pretty good. So this is our case number 3. So we get case number 4 that affect me in 2022. This is our penultimate case. Again, pregnant lady. As I said, I'm in charge of pregnant lady in IJN. So we have a 27 years old pregnant lady that presented with tiredness. So what is the story of this pregnant lady? She herself is a staff nurse. Her only comorbid is bronchial asthma that is well controlled. She is gravida 2 para 1. She is 19 weeks pregnant. During the first pregnancy, she had palpitation at 37 weeks. ECG at the time showed bigeminal, but she delivered uneventfully. After that, she was referred to UITM and noted to have high PVC burden of 41%. So PVC of more than 10 to 50%, we don't really like. Okay, we tend to treat that kind of PVC. However, she was then lost to follow-up. So there's no follow-up and she don't take any medication. She then get pregnant again, which is the current pregnancy, 19 weeks. So at first, she actually come to IJN, didn't see me, see the other doctor, the other cardiologist with palpitation and frequent premature ventricular collapse. At that time, she was 16 weeks pregnant and echo was done. The echo was reported, EF was 35% and severely dilated left ventricle. And I told you just now, automatically, a patient that is pregnant with EF that is low is considered high-risk pregnancy. 35% is even more so, and severely dilated left ventricle. Now, the cardiologist saw the patient. This is the first time the cardiologist saw the patient and told the patient that because the EF is 35% and the patient have severely dilated left ventricle, she needs termination of pregnancy. Okay? And imagine, as a mother, if you receive the news that you need termination by this cardiologist, what would you feel? If you really want the baby. She was devastated. Okay? She was given an appointment to see me in 2 weeks' time. But obviously, in that 2 weeks, she was distraught, right? She was totally depressed. Again, this gives you the point that termination should not be decided by some alone. Even I don't decide on termination alone. It is always must be in multidisciplinary meeting. Everyone have to decide together. And it's not up to us, doctor, to terminate and to say you need to terminate. We can only give advice. So, for example, you can only say to the patient, look, this pregnancy is very, very high risk. The best thing that we can do for you or save, not only save your life, is to terminate the pregnancy. Because remember that ultimately, the decision is on the mother. If she wants to continue to get pregnant, she will continue to get pregnant. And we have to take care of her. Okay? And not only this patient was advised to terminate, the echo was not seen. They only depend on the report, right? So I see her in clinic at 19 weeks pregnancy. So the following are her echocardiogram that was reported as 35%. Okay. So this is the parasternal long axis view of the patient. Okay. And I want you to look carefully at the ECG. So this is the PVC. This is a normal beat. That is a normal beat. Normal beat, PVC. So when I look at this echocardiogram, yes, does look borderline, but it doesn't look 35%, right? In fact, if you're looking carefully as the beat goes, when it go into a normal beat, the contractility is acceptable. Only when it go into PVC that the contractility is not good, right? So the actual ejection fraction is actually not 35%. Maybe it was between 45 to 40%, 45 to 50%, but not 35%. Okay, so beware of assessing ejection fraction in someone with arrhythmia and frequent PVC. There is no left-sided valvular abnormalities. So I go to the short axis view. Now, I go to the short axis view and I try to find a view in which there is no PVC. So in this left view here, we can see there is no PVC. And when there is no PVC, you can see that the contractility is not so bad. In fact, I would say that the contractility is 50% at least, right? And you can compare this one to this one. And you can compare during PVC, the contractility is not good. In fact, after contractility, after PVC, because of the long pause, this contractility here is very good before it becomes normal again. And then it becomes down and becomes supranormal here. Okay. And when we look at the two images above, and we can say that measured at certain beats with PVC, then the EF can wrongly be called depressed when it is not actually depressed. All right. Okay, fine. After I do that, I said, okay, what else can I do in this typical 2D echocardiogram to convince myself that the EF is not 35%? Now, someone with EF of 35%, meaning that they are global problem. I expect the tissue to be really, really unhealthy. But if you look at the septal E prime, it's 7 centimeters per second. Yes, this patient is young, should be much more than that, but at least 7 is considered normal. If you look at the lateral E prime, it's a whopping 14 centimeters per second. It's really, really normal. So surely an ejection of fraction of 35% will give tissue Doppler that is very weak, but this is not the case here. So what is my thought about this first echo? I think the LV is not severely dilated. It's only 5 centimeters. Upper limit for female is 5.2 centimeters. The tissue Doppler is normal. with EF reported as 35%, the tissue Doppler should not be normal. So what is happening here, I think, is that the EF was wrongly called because of the PVCs. And contractility during PVC is low, and the one after PVC is stronger. And if we look carefully, some of the contraction appear to me to be normal. So what do? I start the patient on bisoprolol 2.5 milligram daily. Bisoprolol is safe in pregnancy, but start at lower dose to reduce the PVC burden and hopefully get a better EF measurement. I told her that as far as I can tell, there is no reason to think about termination of pregnancy at the moment. Now, after I've started the bisoprolol 2.5 milligram daily, I repeat the echo 2 weeks after starting bisoprolol. All right. And lo and behold, if you look here, they are no longer very frequent PVC. And when we calculate the ejection fraction is actually normal at 55%, not 35%. We go on apical long axis view and short axis view. Again, we can see that when there is no PVC, the contractility is normal. Right? Obviously, this patient is pregnant. I do not want to make a mistake. What do? I do strain. Okay, all right. Maybe it's still not good. Why do we do strain? And lo and behold, when we do strain, we can see that the GLS is actually normal at negative 18.1%. Okay, so for all intent and purposes, this patient have a normal LV function, if not for the fact that she have frequent PVCs. The RV function is also normal. So what is my final thought on this case? Now, this case shows the possibility of disastrous consequence when EF is wrongly calculated, especially in the presence of arrhythmia. In fact, after we suppress the PVCs with bisoprolol, we can clearly see that the contractility is good. And we have further evidence with normal global longitudinal strain and left atrial strain. We advise the patient to continue pregnancy with regular follow-up, ensuring that the PVC burdens continue to be low. So that is my case number 4. So this is my last case for today, my case number 5. Thank you because you are still with me and I hope you learn things. So this is a typical case of coronary artery disease. So I have a patient with a history of coronary artery bypass graft. He had all vein graft about 19 years ago. So on the left side, he is supported by SVG to LAD and SVG to circumflex. On the right side, he is supported by SVG to right coronary artery. Because he feels well, he defaulted both follow-up and medication for many years. Now come to me in clinic for severe angina, even at minimal exertion. What follow are his echoes when he see me on the 15th of September 2022? So this is a patient echocardiogram. Okay, the LV is not dilated. Okay, but they are hypokinesia at the infralateral wall. So this is a basal and mid-infralateral. This is basal and mid-anteroseptal. This area is supplied by the LAD, and this area is supplied by the RCA, and there are no significant valve abnormalities. When we look at the apical 4-chamber view, again, you can see that the patient have hypokinesia at the basal and mid-infroseptal wall. Also here, hypokinesia all over here. And the apex is slightly hypo as well. And when we calculate the ejection fraction is 44%. So on the mid-range ejection fraction. We do diastology, we get an E over A ratio of 1.35. Remember, when the EF is down, we don't need to do any calculation. We already know that the patient have diastolic dysfunction. The second question is whether the LA pressure is elevated or not. So lo and behold, when we look at the septal E prime, is very weak at 4.64. Lateral E prime is very weak at 8.21. And we will calculate average E over E prime, it is more than 14. So what do we have here? Someone with heart failure with mid-range ejection fraction that have high left atrial pressure at rest. Because the patient have severe angina and depressed ejection fraction, I did the coronary angiogram and graft study, and we do this on the 19th of September 2022. This is one of the worst angiogram that I've ever seen. Remember, this patient left side is SVG to LAD and SVG to circ, but the SVG to circ is stumped, right? So the patient left side is only supported by SVG to LAD. SVG to RCA is also stumped. And you can see that the RCA is severely stenosed here at the mid segment and also at the distal segment here. So this is someone that have only SVG to LAD covering the left side and RCA that is stenosis on the right side. Okay, and so then what is the worst thing is when we look at the SVG to LAD, that is really the patient is depending on now, right? This patient don't have any more supply on the left side. It is severely stenosis at the proximal SVG to LAD there, right? So I decided to proceed with high risk consent. So we put in an IVP, and we decided to tackle both SVG to LAD and the native RCA, right? So this is our stenting of the SVG to LAD. So we have a fairly okay result. So we don't want to be over ambitious with saphenous vein graft. So we pre-dilated the RCA and put DEB distally, and we put stent mid of the RCA, and we have a good RCA result as well. Okay. So this is pre and post SVG to LAD. So what happened in this patient basically is that we actually correct the SVG to LAD and open the SVG to RCA. So he now have quite good support in the left on the right side. Okay. Pre and post RCA stenting on the left on the right side. So after the procedure, thankfully it was uneventful with immediate resolution of angina. Discharged 1 day after with aspirin and Brilinta. Started on heart failure medication. So we start on, I usually, when I start HFmREF, I try to start at least 3 if the patient BP permitted. I see the patient 6 weeks again in my clinic. He feels much better with quality of life back to normal. And the following echo are his echo, right? I do side by side so that you know how to assess echocardiogram for someone with heart failure. This is before and after. We can see that the LV has become smaller. We can see that the infralateral wall and the anteroseptal wall has contracted stronger. Look at the apical 4-chamber view. We can also see the LV has now improved and the ejection fraction has normalized from 44% to 54%. Even better, we can also see that the septal E prime has improved from 4.65 centimeter per second to 6.4 centimeter per second. And in fact, the LA pressure from high LA pressure has become normal LA pressure. So what is my final thought on my last case? So I think this is important because it illustrates what is important to continue medication even when patient already feel well. All the graph is stumped because he doesn't take his medication. My approach in this case is to revascularize completely and to give guideline-directed medical therapy for heart failure with mid-range ejection fraction as soon as possible. And as we can see here, the patient not only improves symptoms-wise, but he also have reverse remodeling of his left ventricle as illustrated by the analysis of the echocardiogram. So I thank you so much for your time with me tonight. I have shared to you 5 cases that I think is really interesting, especially the first 4, where I hope that you learn a lot from the echocardiogram that I showed. So I open the floor for any question. I think last session there is no question. Maybe this session also no question. If you want to ask question, you can type in the chat box. So I can see one question in the chat. So for last case, why do you prefer for PCI versus reduced CABG? Because looking at that vessel, it is doable, right? We can see that the lesion on the SVG to LAD is tight, but it's a tight, discrete lesion that even though can easily be done, but you have to be very careful, anything can happen. And the RCA also can be done. Furthermore, I think whenever you want to do another open heart surgery, the risk is always higher than the first open heart surgery. So that's why I choose PCI for the patient. And I do know that patient might also prefer that PCI rather than doing bypass. So I see someone say, hello, get E certificate. Sorry, Nur Hasina, unfortunately not. I'm just doing this for fun. I just take my time doing this for fun. So no certificate, just knowledge only. Sorry. So SB would like to ask about timing of surgery. We aware that when EF drop to some point of time, then we'll warranted for surgical intervention on valve disease. But do we have a contraindication for surgery? Example, severe AR with LV dimension of 9 centimeter and EF of 21%. Rather to say contraindicated, maybe too late for surgery are more appropriate. Okay, I give you an things, okay? Depend on what is the valve that is involved. is the valve that is involved is aortic stenosis or aortic regurgitation, unless the patient have other problem lah. For example, maybe cancer or what. AS and AR alone, normally there are no absolute contraindication. Okay, no absolute contraindication regardless of the ejection fraction. The only thing is how willing is your patient to accept a certain amount of risk. So patient that you, to give me an example, severe AR, ejection fraction of 21%. In severe AR, after you correct the AR, if AR is the only cause of the EF 21%, normally the EF will go up. So 21% is not a contraindicated. However, we have to tell the patient that because your EF is very low, the risk peri-operatively, like the risk of you surviving the operation is not so good. Okay, maybe the risk of mortality 10%. Are you willing to accept a 10% risk of mortality? So that's what we said. This is different when we are talking about primary mitral regurgitation, because we know when we do primary mitral regurgitation, when we operate on patient with primary MR, the EF will actually come down after the operation. That's why the threshold is higher at 60%. The definition of severe LV dysfunction in someone with primary MR is ejection fraction of 45%. Severe LV dysfunction, right? And normally, when someone with primary MR with EF that is less than 25%, we wouldn't say absolutely, but we try not to do surgery in those EF less than 25% if they have primary MR. Maybe we can do mitral clip, but not mitral valve repair or mitral valve replacement. But many times we see a patient with low EF after operation primary MR, they never get out from their heart failure. So another case is diastolic flow reversal specific for severe AR. The answer is yes, but with a caveat. If your patient is very elderly and they have a very calcified vessel, they might have a hollow diastolic flow reversal that is not meaning that they have severe AR. But if the diastolic flow reversal in the abdominal aorta, I think it is specific regardless of the age of the patient. A computer asked me a question: which scallop of mitral valve disease is repairable and which require replacement? Now, thankfully now, ASUS, all primary mitral valve, doesn't matter which scallop, A1, A2, A3, P1, P2, P3, medial commercial, lateral commercial, all is repairable, provided that your surgeon know how to repair the valve. For primary MR, regardless of the scallop that is involved, all are repairable, depending on the skill of the surgeon. The only case where the primary MR is not repairable is when you are dealing with a very calcified primary MR that can happen very, very rarely. All right, so quite good, quite few questions. I hope my answer is acceptable. Is there anyone else who wanted to ask any questions? So if no question, so thank you so much for spending some time with me tonight. As I said, this is for fun and also to help any of you that wanted to go for surgery, for exam. Don't go for surgery, go for exam. So we will see each other again next week. I will update the timing in my Facebook. Thank you so much and have a good night. Bye.